of the cases have obesity in type 2 diabetes. Other type of diabetes is gestational diabetes mellitus and secondary diabetes. Secondary diabetes usually occurs in pancreatic diseases, endocrine diseases, and other causes like drug-induced causes. Pancreatic diseases like chronic pancreatitis, pancreatectomy, hemochromatosis also lead to secondary diabetes. Also, the endocrine diseases like Cushing syndrome, acromegaly, thyrotoxicosis, they also leads to increased blood sugar level, and they are diagnosed as secondary diabetes. Also, many drugs can cause high sugar level, including steroids, thiazides. Also, there is an entity known as MODY. It's a defect. It's a single gene defect, and it has a dominant inheritance. These are the types of diabetes: diabetes type 1, type 2, gestational diabetes, secondary diabetes, and MODY. Regarding epidemiology of the diabetes mellitus, up to 2030, it is postulated that the diabetes, the patient that have diabetes will increase up to 366 million. In the developed country, there is 40% increase in the cases of diabetes, whereas in the developing countries like ours, there is 200% increase in the cases of diabetes. And also, diabetes is an independent risk factor for coronary artery disease. 70% of the patient with diabetes, they die of heart disease. In Southeast Asia, there are around 50 million cases of diabetes. And in USA, there is around 20 million people affected by the diabetes mellitus. So it's becoming a rapidly important and increasing disease condition in the developing country like ours. So what is the impact of the diabetes mellitus in the person suffering from the high blood sugar level? These are the impacts. They have 2 to 3 times more chance of having heart disease, 6 times more chance of having stroke, 10 to 20 times more chance of having blindness, 20 times more chance of having leg amputation due to gangrene. It is also second leading cause of the renal failure. Also, on the patients suffering from diabetes, they have multiple other comorbidities and disabilities like neuropathy, peripheral vascular disease, sexual dysfunctions, infections. Also, the hospitalization rate is 2 times more in those patients suffering from diabetes. Regarding the pathogenesis, in type 1 diabetes, it is mostly a T-cell mediated autoimmune disease. Where the insulin secreting beta cells in the pancreas, they are destructed by the T-cell mediated autoimmune disease. It is supported by the evidence of histology finding like infiltration of the islet cells with macrophages and T lymphocytes and B lymphocytes. Also, there is a viral infection of the pancreas, mostly caused by Coxsackie-B4 virus, retrovirus, rubella virus, and MOM virus. In patients with type 1 diabetes, we can find islet cell antibodies, GAD antibodies, that is glutamic acid decarboxylase antibodies. Also, there are evidences that the type 1 diabetes mellitus is associated with many other autoimmune diseases like Hashimoto thyroiditis, Addison's disease, pernicious anemia, vitiligo. These are the conditions associated with type 1 diabetes, so it is considered as an autoimmune disease. And also there are genetic factors in this condition, like those with HLA halotype DR3 and DR4, they have increased susceptibility to develop type 1 diabetes mellitus. So the basic pathogenesis of type 1 diabetes mellitus is there is genetic susceptibility, that is the DR3 and DR4. And in those patients with genetic susceptibility, if there is environmental trigger like viral infections, the immunologic activation there is immunological activation. B lymphocyte and T lymphocyte are activated, and they infiltrate the islet cell of the pancreas, and there ensues the inflammatory reaction in those pancreatic cells, and they produce autoantibodies and destroy the islet cells of the pancreas, which further causes decrease in secretion of the insulin, and thus the diabetes mellitus ensues. Regarding the pathogenesis of type 2 diabetes mellitus, in type 1 diabetes mellitus, there is a decreased production of the insulin due to autoimmune destruction of the islet cells of the pancreas, whereas in type 2 diabetes mellitus, there is insulin production is fine, but there is insulin resistance. The insulin receptors are not working properly in type 2 diabetes mellitus. There is resistance to the action of insulin in liver, muscles, and thus the metabolic syndrome occurs. And the metabolic syndrome usually comprises of central obesity, hypertension, and dyslipidemia, also diabetes as well. And there is also pancreatic B cell failure, in which the B cell lose the ability to respond early to the rise in glucose, and that causes early postprandial hyperglycemia. So if the fasting hyperglycemia is more than 200 mg, then it will cause glucotoxicity, and again the insulin secretion will be impaired in that case. So more than genetic predisposition, like in type 2 diabetes mellitus, in type 2 diabetes mellitus, in monozygotic twins, it has been recorded that the concordance rate is 100%. So if one twin of the monozygotic twins have diabetic, the other twin will also develop diabetic. And regarding the environmental factor, there is relation between diabetes and obesity. Also metabolic syndrome. Those who have metabolic syndrome, like who have central obesity, hypertension, and dyslipidemia, they eventually develop diabetes mellitus, and they are categorized as type 2 diabetes mellitus. So in type 2 diabetes mellitus, there is lack of insulin, which causes increase in the plasma glucose level, and the patient will then have glucosuria. That is, they will pass more glucose in the urine. So since the glucose is a very osmotic substance, along with the glucose, the water is also lost in the urine. So the patient will have increased thirst, and patient also will have polyuria. The symptoms that we always describe as those of diabetes mellitus, like polyuria and increased frequency of micturition and increased thirst, is due to this factor. Also, there is wasting, muscle wasting. Most of the patients, they complain that they have weight loss, and when we check the blood glucose level, it is usually raised. So the lack of insulin in those patients, that leads to decreased impaired protein synthesis, and which leads to muscle wasting and subsequent weight loss. Also, there is increase in lipid breakdown due to lack of insulin. So there is increased free fatty acid in the blood. So regarding the clinical presentations, most patients with the diabetes mellitus, they complain all these symptoms, like they have increased thirst, increased appetite, increased micturition, and weight loss. Most of the patients, they complain about these symptoms. Also, some patients, they present with recurrent infections like boils, furuncles, genitourinary infection, genital candidiasis. These infections, the patients also present with these infections. This genitourinary infection and genital candidiasis is mostly because the patients with high blood sugar level, they pass sugar in urine. So it is a good media for the bacteria to grow. So they have more chance of having genitourinary infection and also candidiasis. Type 2 diabetes mellitus, there can be weight gain because they are associated with metabolic syndrome, but they may also present with weight loss as well due to impaired protein synthesis and subsequent muscle wasting. Also, some people can present in chronic renal failure because of the diabetes. They eventually develop renal impairment, and they present with the complaint of chronic renal impairment like swelling of the legs, decreased urination, anemia. Also, they can present with the other features of complication of diabetes that includes retinopathy, like they can complain diminished vision, neuropathic features like pain in the legs or weakness, also peripheral vascular disease. They can also present gangrenes of the legs. In clinical examination of those patients, there could be obesity like in type 2 diabetes mellitus, or weight loss in type 1 diabetes mellitus. They may have increased blood pressure as it is associated with metabolic syndrome. In examination of hands, there could be prayer sign, Dupuytren's contractures. In skin, there could be boils, furuncles, vitiligo, as boils and furuncles are common in those patients with impaired glucose tolerance, as well as increased glucose level. Vitiligo can be present as they can be associated with type 1 diabetes mellitus. Also in eyes, there could be presence of diabetic retinopathy, also xanthomas, arcus, cataract, and in legs there could be edema, necrobiosis, lipoidica. Peripheral pulses could be absent or feeble due to peripheral vascular diseases. There could be gangrene as well, also fungal infections, muscle wasting, sensory loss, impaired vibration, neuropathic foot ulcers, and in fundoscopy there could be features of diabetic retinopathy. So all this could be like due to diabetes itself, and as well as due to the complications of the diabetes mellitus. Regarding the diagnosis of diabetes mellitus, we say the normal plasma glucose level fasting is 110 to 125, and PP, that is postprandial glucose level, is usually less than 140. So if the level of glucose in fasting state is more than 126, then it is known as more than 126, but less than 200. It is known as impaired glucose tolerance. Also, the postprandial glucose, if it is 140 to 199, and then the patient is having impaired glucose tolerance. It's not yet called diabetes, but those patients have impaired glucose tolerance. So for diagnosis of diabetes mellitus, we should have symptoms of diabetes mellitus like we explained before, like polydipsia, polyphagia, polyuria, that is, or repeated infections, plus there could be random plasma glucose level more than 200, then it is sufficient to diagnose diabetes mellitus. Or if the fasting glucose level is more than 126 and PP glucose level is more than 200 after 75 grams of sugar intake, or if the HbA1c is more than 7. So the criteria for diagnosis of diabetes is if we have random blood sugar level of more than 200 with symptoms of diabetes, or if there is fasting glucose is more than 126 with the postprandial glucose of more than 200 mg after 75 grams of sugar intake, and if there is HbA1c of more than 7. Usually we do the postprandial with the meal in our clinical practice, but for exam purpose, we should know that it is kind of OGTT, that is oral glucose tolerance test. We give a patient 75 grams of sugar, and after 2 hours of the intake of the sugar, we measure the plasma glucose level. And if it is more than 200, and then the patient can be diagnosed as diabetes mellitus. So in patient who are diagnosed diabetes mellitus for the first time, what should we look further in those patients? We should investigate those patients for impact of the diabetes mellitus. Also, we should also look for the complication of the diabetes mellitus in those patients. Like we should look for CBC, that includes total count, differential count, hemoglobin, ESR, and in urine we should look for sugar, microalbumin, albumin, ketones, also serum creatinine levels, serum electrolytes, lipid profile, HbA1c, glycolated hemoglobin, that is the hemoglobin, the portion of the glycated hemoglobin, which denotes the insulin sugar load of the patient in the past 3 months. If the HbA1c is more than 7, then the patient is having impaired glucose levels since more than 3 months of the time. Also, we should look for chest X-ray and ECG to look for cardiac complications as well, because as we discussed earlier, the most common cause of the mortality in patients with diabetes mellitus is coronary artery disease and cardiac complications. So we should screen those complications when we diagnose the diabetes mellitus, mostly in cases of type 2 diabetes mellitus, because they already have many impaired systems due to diabetes, as well as due to associated metabolic syndrome. Similarly, we are going to talk about the complications of diabetes mellitus. There are many complications like acute complications and chronic complications. Acute complications include diabetic ketoacidosis, hypoosmolar hypoglycemic state, HHS, also hypoglycemia, acute infections. These are the acute complications of diabetes mellitus. And also there are many chronic complications. Chronic complications are easily classified as microvascular and macrovascular. Microvascular complications include retinopathy, nephropathy, and neuropathy. Also, there is macrovascular complications like big vessels of the body are involved in heart, and it is known as coronary artery disease. In brain, it is known as cerebrovascular disease, and also peripheral vascular disease. So the patients with diabetes mellitus, they have more chance of having heart attack, stroke, and also peripheral vascular disease causing gangrene and all that stuff due to the macrovascular complication of the diabetes. Also, there are many microvascular complications, and that leads to retinopathy, and the retinopathy leads to blindness. Those patients also have renal impairment due to the nephropathy causes nephropathic effect of the diabetes. Also, they also present with neuropathy, and the neuropathic manifestations are very diverse. They may present as small nerve problems like tingling or pain sensation, or they may also have single nerve involvement and have mononeuritis multiplex. So there is a diverse group of nerves affected by diabetes mellitus. We will also discuss a little about goals of the diabetes management in the diabetes mellitus. So up to now, we have discussed about the types of diabetes mellitus, the pathophysiology, clinical presentation, and also diagnosis of the diabetes and complication of the diabetes mellitus. So we'll just be discussing about some goals for management of diabetes mellitus, and regarding the patients who present with diabetes, they should provide relief from the symptoms. Like, what are their symptoms? Some may present with features of neuropathy, so we'll have to address those problems. Also, it is connected with the control of the blood sugar level. So if we achieve the good glycemic control in the patient, the most symptoms of the patient, they also decrease due to the control of the blood sugar. So we have to control the blood sugar level. For that, we can use insulin or oral hypoglycemic drugs. Also, the non-pharmacological treatment is also equally important, like dietary advice in those patients about regarding the low sugar diet and weight control, decrease in the truncal obesity, also associated conditions like hyperlipidemia, hypertension, and also good physicians should also detect the complications of the diabetes mellitus before the patient can even ask you about or complain about the complications. We should try to detect the complications of diabetes mellitus and also manage those complications. And patient education is a key to manage the diabetic mellitus, because it's not like infection. It doesn't go away in 2 days. It will remain lifelong in those patients. And if we can't educate the patient will eventually come to us with acute complications or chronic complications. So patient education is very important in the management of the diabetes. And most people also have curiosity about what is the satisfactory control of the diabetes. That, as we all know, it is not cured, but what is the satisfactory limit of control of the diabetes? So these are the parameters, like fasting blood glucose level. It should be kept in the range of 80 to 110. Postprandial plasma glucose should be kept in the level of 120 to 140. Though in most elderly patients and hospitalized patients, it is quite accepted that the level can be up to 180. But in healthy and young patients, we should try to keep it below 140. HbA1c should be less than 7. SGL level should be more than 40, LDL level should be less than 100, TG level should be less than 150, total cholesterol should be less than 200, and the BMI should be less than 23. So the BMI goal can only be achieved if the patient also carries on the non-pharmacological measures. We'll talk about the management of the diabetes in later session, because it is also very vast. So if anyone likes to ask me about the things we just discussed. Any questions, if anyone likes to ask me? So basic things that we should remember for examination purpose, like
ma'am, type 1 type 2 ma alikati difference भन्दिनु
टाइप 1 टाइप 2 मा डिफरेन्स भनेको एउटा चाहिँ टाइप 1 भनेको चाहिँ मोस्टली यङ एज ग्रुपमा देखिन्छ हैन, युजुअली बिलो 20 इयर्स अफ एज भन्छ। यङ एज ग्रुपमा देखियो भने त्यो युजुअली टाइप 1 डायबिटिज भयो। टाइप 2 डायबिटिज भनेको युजुअली यङ्गर पपुलेसन भन्दा अलिकति माथिको पपुलेसन विथ एसोसिएटेड विथ ओबेसिटी मेटाबोलिक सिन्ड्रोमसँग एसोसिएटेड चाहिँ टाइप 2 डायबिटिज मेलाइटिस भयो। अल्सो देयर इज त्यो चाहिँ हाम्रो एज ग्रुपमा हिसाबमा भयो हैन। अर्को हिसाबमा भन्दाखेरि चाहिँ अब हाम्रो यो डायग्नोस्टिक क्राइटेरिया त सेम नै हो दुईटैको। दुईटैको सुगर लेभल यति भयो भनेपछि हुन्छ हैन। अब अर्को कुरा चाहिँ डिफरेन्स भनेको चाहिँ प्याथोजेनेसिसमा डिफरेन्स छ। अघि प्याथोजेनेसिस पढाएको अनुसारले टाइप 1 को प्याथोजेनेसिस र टाइप 2 को प्याथोजेनेसिस डिफरेन्स छ। टाइप 1 मा भनेको चाहिँ जुन इन्सुलिन प्रोड्युसिङ सेल्सहरू छ प्यान्क्रियासको आइलेट सेल्स भन्ने हुन्छ, त्यो सेल्सहरूमा चाहिँ हाम्रो के हुन्छ डिस्ट्रक्सन हुन्छ, अटो इम्युन मेकानिजमले गर्दा डिस्ट्रक्सन भएर टाइप 1 मा चाहिँ इन्सुलिन प्रोडक्सन नै कम हुन्छ। तर टाइप 2 मा के हुन्छ भन्दाखेरि इन्सुलिन प्रोडक्सन कम हुने होइन कि इन्सुलिन रेजिस्टेन्ट हुन्छ टाइप 2 मा चाहिँ। टाइप 1 मा चाहिँ इन्सुलिनै नभएर सुगर लेभल इन्क्रिज हुन्छ, तर टाइप 2 मा चाहिँ इन्सुलिन चाहिँ हुन्छ तर इन्सुलिन रेजिस्टेन्स हुन्छ बडी चाहिँ। त्यो भएको भएर चाहिँ त्यसले जसरी त्यो इन्सुलिन अमाउन्टले जसरी काम गर्नुपर्ने त्यसरी गर्दैन, त्यो भएको भएर चाहिँ पेसेन्टले डायबिटिज डेभलप गर्छ। अर्को भनेको चाहिँ युजली अब टाइप 1 अघि भने जस्तो यङ पनि भयो, प्लस टाइप 1 चाहिँ युजली थिन पेसेन्ट्सहरू हुन्छ भने टाइप 2 चाहिँ युजली ओबेज पेसेन्टहरू हुन्छ भनेर भन्छ। किनभने टाइप 2 मा चाहिँ एसोसिएटेड मेटाबोलिक सिन्ड्रोम पनि हुन्छ। मेटाबोलिक सिन्ड्रोम भनेको अघि भनेको कुराहरू जस्तै ट्रङ्कल ओबेसिटी, हाइपरटेन्सन, डिस्लिपिडेमिया, यो सबै भएको बिरामीहरूलाई युजली टाइप 2 डायबिटिज मेलाइटिस हुन्छ। अरू भनेको चाहिँ अब टाइप 1 चाहिँ हामीले अटो इम्युन प्रोसेस भन्यौँ नि त हैन अघि। टाइप 1 मा चाहिँ हाम्रो यो के भन्छ अटो इम्युन प्रोसेस भएको भएर एन्टिबडिजहरू हुन्छ बडीमा, लाइक आइलेट सेल एन्टिबडिज, यो जिएडी एन्टिबडिज, यिनीहरू एन्टिबडिजहरू हुन्छ। टाइप 2 मा एन्टिबडिजहरू खासै हुँदैन। अर्को टाइप 1 मा एसोसिएटेड अटो इम्युन डिजिजेसहरू पनि हुनसक्छ, लाइक एडिसन्स डिजिज, थाइरोइड डिसअर्डर्स, यिनीहरू सबै चाहिँ टाइप 1 मा हुन्छ भने टाइप 2 मा त्यस्तो युजली हुँदैन। अर्को चाहिँ यो आइडेन्टिकल ट्विन्सको कुरा गरेको थिएँ मैले अघि, कताको गरेको थिएँ। टाइप 2 मा चाहिँ युजली एउटा ट्विनलाई टाइप 2 मा चाहिँ मोनोजाइगोटिक ट्विनलाई एउटालाई भयो भने अर्कोलाई हुने चान्स चाहिँ 100% हुन्छ। तर टाइप 1 मा चाहिँ त्यस्तो हुँदैन। टाइप 1 मा चाहिँ एउटा ट्विनलाई भएको छ भने अर्को ट्विनलाई हुने चान्स चाहिँ लेस देन 50% हुन्छ भनेर भन्छ हैन। अर्को भनेको चाहिँ टाइप 1 भन्दा टाइप 2 अहिले एकदमै प्रिभिलेन्स छ, टाइप 2 चाहिँ मोर प्रिभिलेन्ट भन्ने भयो। अर्को भनेको चाहिँ कम्प्लिकेसनको हिसाबले कुरा गर्दाखेरि युजली टाइप 1 मा चाहिँ डायबिटिक किटोएसिडोसिस मोर कमन हुन्छ भन्छ, टाइप 2 मा चाहिँ यो एचएचएस चाहिँ मोर कमन हुन्छ भनेर भन्छ। डिफरेन्स चाहिँ अब यति नै हो भनौँ। टाइप 1 को एज अनि त्यसपछि बडी कस्तो हुन्छ, त्यसपछि प्रिभेलेन्स कस्तो छ, ट्विन्समा के छ, त्यसपछि कम्प्लिकेसनहरू के हुन्छ, अटो एन्टिबडिज हुन्छ कि हुँदैन, त्यो अनुसारले डिफरेन्सिएट गर्ने हो। अरू के प्लस हाम्रो ट्रिटमेन्टमा नि डिफरेन्स हुन्छ। डायबिटिजको हाम्रो मेन उद्देश्य के हो त, किन छुट्याउने त हामीले टाइप 2 हो भनेर हामीलाई चाहिँ जुन टाइप भयो नि एउटै हो भन्ने जस्तो लाग्न सक्छ होइन। टाइपको चाहिँ हामीलाई इम्पोर्टेन्स भनेको चाहिँ ट्रिटमेन्टमा आउँछ। टाइप 1 लाई चाहिँ हामीले इन्सुलिन दिनै पर्ने हुन्छ किनभने पेसेन्टको बडीमा इन्सुलिनै हुँदैन, उसको बडीले इन्सुलिन प्रोड्युसै गर्न सक्दैन। त्यो भएको भएर टाइप 1 को चाहिँ हामीले ट्रिटमेन्ट इन्सुलिन दिएरै गर्छौँ। टाइप 2 को चाहिँ पहिला ओरल हाइपोग्लाइसेमिक दिने, त्यसपछि भएन भने इन्सुलिन दिने, त्यो चाहिँ पेसेन्टको सुगर लेभल हेरेर गर्न सकिन्छ। तर टाइप 1 मा चाहिँ हामीले इन्सुलिन दिनै पर्ने हुन्छ। त्यसको लागि चाहिँ डिफ्रेन्सिएसन इम्पोर्टेन्ट हो। अरू केही क्वेसन छ?
मैम फ्यामिली रिलेटेड चाहिँ कुन हो?
फ्यामिली रिलेटेड भनेको फ्यामिली नै रिलेटेड भन्दा पनि जस्तै ट्विन्ससँग रिलेटेड भनेको चाहिँ टाइप 2 हो। टाइप 2 मा चाहिँ तपाईँको आफू जस्तै जेनेटिक मेकअप भएको मान्छेलाई चाहिँ मोर प्रिभिलेन्स भयो। टाइप 1 मा पनि जेनेटिक रोल चाहिँ छ, तर टाइप 1 मा चाहिँ यो अघि कुरा गरे जस्तै एचएलए DR3 र एचएलए DR4 हेलो टाइप भएको मान्छेहरूलाई चाहिँ धेरै डायबिटिज हुन्छ भन्ने हो। जेनेटिक चाहिँ भनेर जुन भन्छौँ हामीले जेनेटिक चाहिँ टाइप 2 हो, टाइप 1 होइन। टाइप 1 मा जेनेटिक फ्याक्टर त छ, तर त्यो एचएलए DR3 र DR4 सँग रिलेटेड हो। तर जेनेटिकली जस्तै आमालाई भयो भने छोराछोरीलाई हुन सक्ने, अथवा के भन्छ ट्विनलाई भयो भने अर्को ट्विनलाई हुन सक्ने भने चाहिँ टाइप 2 डायबिटिज मेलाइटिस नै हो। अरू के जस्तो यो जेनेटिक भनेको चाहिँ एउटा अर्को खालको मैले अघि डिस्कसन पनि गरेको थिएँ एउटा टाइप अफ डायबिटिज भनेर एमओडीवाई भन्ने यसमा चाहिँ जिन डिफेक्ट हुन्छ यो जिन डिफेक्ट चाहिँ युजली फ्यामिलीमै रन हुन्छ त्यो भएको भएर यो पनि एउटा टाइप अफ जेनेटिक डायबिटिज मेलाइटस हो जस्तै एउटा सिंगल जिन डिफेक्ट हुन्छ यसको डोमिनेन्ट इनहेरिसन हुन्छ त्यो भनेको चाहिँ एभ्री जेनेरेसनमा चाहिँ यो जिन डिफेक्ट पास हुन्छ अनि त्यो भएपछि चाहिँ एभ्री जेनेरेसनमा चाहिँ डायबिटिज देखिन्छ त्यसलाई चाहिँ एमओडीआई भनिन्छ तर जेनेटिकली भनेर चाहिँ हामीले एसोसिएट गर्ने चाहिँ टाइप 2 लाई नै हो टाइप 1 भन्दा पनि मेन चाहिँ हामीले अब डायबिटिजको थाहा पाउनु पर्यो प्याथोजेनेसिस अलिकति थाहा हुनु पर्यो त्यसपछि सिम्पटम्स थाहा हुनु पर्यो त्यसपछि कम्प्लिकेसन्स थाहा हुनु पर्यो पेसेन्ट सिम्पटम्स थाहा भएपछि पेसेन्ट प्रेजेन्टेसन त्यही अनुसारले भइहाल्यो त्यसपछि हामीले डायग्नोसिस कसरी गर्ने भनेर यो भ्यालुजहरू चाहिँ याद हुनु पर्यो यो अलिकति कन्फ्युजिङ हुन्छ जस्तै पेसेन्टको पोस्ट प्रान्डियल चाहिँ सुगर लेभल चाहिँ 200 छ भन्यो नि यो 200 होइन 199 200 छ भने त डायबिटिज भइहाल्यो 199 छ यो डायबिटिज हो कि होइन भनेर भन्यो भने हामीलाई लाग्न सक्छ यो डायबिटिज हो भने त्यो डायबिटिज भन्छ त्यो चाहिँ इम्पेयर्ड ग्लुकोज टोलरेन्स भयो त्यही भएर भ्यालुजहरू चाहिँ अलिकति याद गर्नु पर्यो इक्जाम पर्पजको लागि चाहिँ अरू भनेको चाहिँ अब यो कम्प्लिकेसन्सहरू पनि मैले यहाँ छोटकरीमा चाहिँ भन्दै तर यो एकदम राम्रोसँग चाहिँ उसमा लेखेकै छ हाम्रो डेभिडसनमा एकदम राम्रोसँग कम्प्लिकेसन्सको बारेमा नि एक्सप्लेनेसन गरेको छ त्यही भएर त्यो पनि एकचोटि यसो हेर्दा हुन्छ
हुन्छ त्यो डायबिटिसमा चाहिँ कस्तो
हजुर
प्रोलङ उन्ड हुन्छ त्यो डायबिटिसमा प्रोलङ
हजुर हजुर
पेसेन्टहरुमा त्यो कस्तो हुन्छ
अब त्यो चाहिँ के भन्छ डायबिटिजको कम्प्लिकेसनले गर्दा नै हो अब पेसेन्टको चाहिँ इन्फेक्सनहरू भइराख्ने त्यसपछि वुन्ड हिलिङ राम्रोसँग नहुने भनेको चाहिँ यो चाहिँ डायबिटिजको कम्प्लिकेसन हो यो चाहिँ कसरी हुन्छ भन्दाखेरि चाहिँ यो ब्लड सुगर लेभल हाई भएपछि बडीको म्याक्रोफेजको यिनीहरूको एक्सनमा चाहिँ स्लो डाउन हुन्छ अनि बडीको त्यो जति एक्टिभ हुनुपर्ने हो त्यो इन्फेक्सन कन्ट्रोल गर्ने सेल्सहरू जति एक्टिभेट हुनुपर्ने हो त्यस्तो चाहिँ एक्टिभेट हुँदैन राम्रोसँग त्यो भएको भएर चाहिँ मोस्टली अब यो इन्फेक्सन बढी हुने प्लस वुन्ड हिलिङ ढिलो हुने चाहिँ त्यो कारणले गर्दाखेरि हुन्छ डायबिटिजहरूमा अर्को चाहिँ एउटा चाहिँ त्यो म्याक्रोफेजको कुरा भयो अर्को चाहिँ हाम्रो कम्प्लिकेसनहरूमा ऊ पनि छ पेरिफेरल भास्कुलर डिजिजहरू छ होइन त्यो भए पनि भेसल्सहरूमा चाहिँ अब के भन्छ त्यसलाई अक्लुजनहरू भएर त्यो जुन पार्टमा इन्फेक्सन भएको छ त्यो पार्टमा ब्लड सप्लाई राम्रोसँग नहुने अर्को न्युट्रिएन्ट सप्लाई राम्रोसँग नहुने त्यो भएको हिसाबले पनि त्यो पार्टको पेरिफेरल भास्कुलर डिजिजले गर्दाखेरि पनि त्यो पार्टको वुन्ड हिलिङ चाहिँ कम हुने हुन्छ एउटा चाहिँ अर्को चाहिँ म्याक्रोफेज एक्टिभिटीमा पनि अफेक्ट गर्छ अरू के अर्को कुरा चाहिँ डायबिटिज भनेको एकदम कन्स्ट्यान्ट के भन्छ त्यसलाई कन्स्ट्यान्ट एउटा स्टेट अफ इन्फ्लामेसन हो कि डायबिटिज भनेको चाहिँ त्यो बडीमा चाहिँ यो प्रकारले त्यो इन्क्रिज ब्लड सुगर लेभल भएको भएर त्यहाँ चाहिँ इन्फ्लामेसन चाहिँ कन्टिन्युस भइरहेको हुन्छ बडीमा जस्तै अब त्यो इन्फेक्सन मात्र हुँदाखेरिको इन्फ्लामेसन होइन कि यसलाई चाहिँ एउटा क्रोनिक इन्फ्लामेटरी स्टेट जस्तो मान्छ कि आजकल डायबिटिजलाई त्यो भएको कारणले गर्दाखेरि पनि पेसेन्टको वुन्ड हिलिङ पनि राम्रो नहुने प्लस मोर प्रोन टु इन्फेक्सन हुने चाहिँ त्यो कारणले पनि हो एउटा चाहिँ हाम्रो इम्युन सिस्टममा नै त्यसले डिसफङ्सन गराउँछ डायबिटिजले अरू छ कुनै क्वेसन अरू त्यो याद भएको केही क्वेसनहरू छ भने यसो सोध्नुहोस् डायबिटिजको रिलेटेड अब ट्रिटमेन्टहरुमा के पर्छ भनेर चाहिँ म अर्को क्लासमा भनौँला। जस्तै अब एउटा चाहिँ हाम्रो नन फार्माकोलोजिकल ट्रिटमेन्ट कुरा गर्नु पर्यो, अर्को इन्सुलिनको कुरा गर्नु पर्यो, अर्को ओएचएहरुको कुरा गर्नु पर्यो। त्यो अलि लामै हुन्छ त्यो कुरा, त्यही भएर मैले आज नगरेको। यति इन्ट्रोडक्सन जस्तो भनौँ न, डायबिटिजको इन्ट्रोडक्सनमा के कम्प्लेन के सोध्नु पर्ने के छ भने